all. Uh, just watch this video for practical points. I just want to have some final revision series for your practicals for general surgery residents. In case of an obstructive jaundice, they will ask sometime what is indication of DLAP. So there is a 4% chance of missing the malignancy in the imaging, so we need to perform a DLAP and also to look for surface liver metastasis. So next, what is the indication for PET-CT in case of an obstructive jaundice in patient with, if you are suspecting cholangiocarcinoma or seeing gallbladder, to rule out omental deposit, suspicious lesion in chest X-ray, if ultrasound abdomen, indeterminate lesions in the liver and marginal resectable tumors. Remember, CA19-9 is a prognostic marker, not a diagnostic one. Endo ultrasound is useful for T-staging and image-aided FNAC from notes. If you are suspecting cholangiocarcinoma, it will be helpful, or even if in case of a pancreatic malignancies. In obstructive jaundice, the one point they will ask you about how will you proceed for surgery. Always clearly say, I will optimize the patient for surgery, then I will post for surgery. So what are all the optimization? The first important is IV fluids. IV fluids to improve the renal function, because IV fluids mainly helpful to improve renal function, because if kidneys fail, it may lead to hepatorenal syndrome, fail to phagocytose nephrotoxic toxin, deposition of bile salts and block renal tubules. In case of hyperperfusion, angiotensin II is activated. Also, you need albumin, hemoglobin. You need to improve albumin, hemoglobin. Just physiotherapy, nutritional improvement is very important. We know Whipples consist of JJ, choledochogestomy and pancreatic chogestomy, but initially Whipples didn't perform pancreatic chogestomy. Then he had a modification to do this for anastomosis. Pylorus, it's not so this is not it's just an add-on. Don't comment this. Pylorus preserving pancreatic duodenectomy, traversal long wave procedure. So the advantage is it increases gastrointestinal function. It avoids the complication associated with the gastrectomy, dumping syndrome. Some examiners may ask, pancreaticogastrostomy is better than pancreaticogynostomy because acidic medium is neutralized by alkaline medium from pancreatic juice. Stomach, there is an increased vascularity, less chance of leak, and if collection is present, it will be aspirated by rinse tube. Most of them depends upon the pancreatic duct and the contour of the pancreas. They prefer the anastomosis, pancreatic gastrostomy or pancreatic gynostomy. If some examiners ask what is the advantage, then comment these points. So if obstructive jaundice in case of malignancy, if inoperable, perform triple bypass, gastrogynostomy, hepaticogynostomy, either cholecystogynostomy or hepaticogynostomy and duodenogynostomy. So what is white bile? Some examiners may ask. It's a misnomer. So it is a mucus secreted from gallbladder in case of cystic duct obstruction. Choledochoduodenostomy can be done if CVD is more than 1 centimeter. So what are all the complications of choledochoduodenostomy? Very important, some syndrome is the contents reflexing into the CBD. Funnel syndrome, ampullary stenosis, biliary sludge, and impacted giant stones, primary CBD stones may form. Obstructive jaundice in case of supramesenteric vein involvement. If plan to remove a segment, we can go with internal jugular venous graft. If there is a sleeve resection performed, we can go with saphenous vein graft.